Good morning, Indu ma'am. Good morning, Priscilla ma'am. Good morning, Tanvi. Good morning, Sanjay sir.
Good morning.
Good morning.
Do you want to just do a trial run to make sure the images and the videos are loading? You can share screen and try.
No, I'm not allowed to share.
Good morning, everyone.
Good morning,
Good
sir.
morning, sir.
Good morning.
Tanvi, can you allow me to share
Yeah,
screen?
yeah. 1 second. I'll just, I think IP say Nilesh is the host. He's not yet
Okay.
joined because I'm not getting the hosting.
Okay.
I'll look into it.
You can message him, Tanvi.
Yes, ma'am. I'll just...
I like to say Tanvi, SRCC Tanvi. Or Tanvi A and Tanvi B. That might be B Bafna and A Modi.
Good morning, Indo.
Good morning. How are you?
All well. Sorry, I had to leave early that day. I could not attend your say. Dr. Lalwani had to leave early. That Sangli ka thing, na? Yes.
Absolutely no problem.
Gone well. Na?
Absolutely. Yeah.
Priscilla madam आए क्या?
Huh, ma'am is here.
Good morning, madam.
Morning. How are you?
All well.
We are sitting together, Tanvi and me. The light on.
Morning,
Please
Dr.
start.
So, good morning, everyone. Welcome to our sixth session of Pulmo Radio Crosstalk. I think we can all agree that because of our fabulous interactions in the last 5 meetings, we have learned a lot. And when we say correlate clinically or correlate radiologically, we actually can now, and we have gained a lot of more wisdom, lot of insight into our own cases, be it the radiological or the clinical presentation. I'd like to welcome Dr. Rawat sir. Thank you for giving us this opportunity. Dr. Nehal Shah ma'am has not been able to join. Dr. Indu Khosla ma'am, Dr. Hiren sir, Dr. Sonal ma'am, whose brainchild this was. And I'd like to welcome our presenters and mentors for today. Mentored by Dr. Sanjay Bafna sir from Bharati Vidyapeeth University, Pune, and Dr. Priscilla Joshi ma'am, Head of Radiology, Bharati Vidyapeeth University, Pune, and the presenter, Dr. Tanvi Bafna, the Pediatric Pulmonology Fellow today. Before we begin, I'd like to invite Dr. Rawat sir to please say a few words, followed by Dr. Indu ma'am to please welcome and introduce the session.
Thank you, Tanvi, and a warm welcome from IIP Tanarsi. I hope all the delegates who have joined today morning, early morning, are enjoying this session because I think this is the sixth or seventh in the series of Pulmo Radio Cross Talks, and I think it is giving very important learning to all the people across in India. And I'm sure that those people who joined in this mornings, they are really committed to learn some very important aspects of pulmonary radiology, and it is aptly supported by radiologists from SRCC Mumbai, Dr. Hiren Panwala and others. And I hope that again this session proves to be useful to all of you. So without taking much time, I'll request Dr. Indu Khosla to take over and start the session, please. Thank you.
Thank you, everyone. And this time the format is a little different because Dr. Joshi, our radiologist from Pune, Bafna, Dr. Bafna's team, is going to go through the images. We don't have the images this time, and we will have expert comments from our team. But it's been a great learning, and over to you, Tanvi too, to start the presentation.
First of all, thank you to Dr. Sanjay Bafna sir and Dr. Prisha Joshi to presenting a case. So, ma'am, it all yours. I am sure that I might not have to add anything what your viewers say. So, yeah, please go ahead.
Thanks, Cyril.
Tanvi, I request you to start screen sharing.
Yeah. Are my slides visible?
Yes.
Good morning, everyone. Today I'll be presenting a case of multiple cystic lesions. So we had a child, Miss A, 15-year-old female, who presented to us 8 months back with complaints of recurrent dry cough and dyspnea on exertion since the last 4 years. The cough was dry in nature and occurring approximately every 1 to 2 months and been recurrent since the last 4 years. She was also experiencing exertional dyspnea, particularly while walking to school or walking upstairs or engaging in physical activities. These episodes were being treated on OPD basis and they were non-progressive in nature. She had no other significant complaints, no history of any fever, anorexia, weight loss, or any hemoptysis, no history of any chest pain, palpitations, or excessive sweating, and no other systemic complaints as such. She's first by birth order, born out of a non-consanguineous marriage, delivered term by normal vaginal delivery with a birth weight of 3.5 kgs with no NICU stay. She's developmentally normal for age and immunized up to age. Her growth wise, she's underweight, 33 kgs at third centile. Height, she's growing well, 149 centimeter, third to 50th centile, and BMI wise, she's underweight for her age. So when she presented to us on examination, she was afebrile, a heart rate of 100 per minute, pulses were well felt, perfusion was good, CRT was less than 3 seconds. Respiratory rate wise, there was no distress, RR of 22 per minute, and she was maintaining saturations on room air at 95%. There was only pallor, no lymphadenopathy, and no clubbing. On systemic examination, CVS wise, it was normal. S1, S2 was heard, no murmur. Respiratory system wise, air entry was bilateral equal and there was bilateral expiratory wheeze present. Per abdomen, there was no hepatosplenomegaly. Then we digged into her past records. Unfortunately, from 2016 to 2023, she's been taken to an outside hospitals and we don't have any documents available. So this was all from the parents who told us this history. So in 2016, at 6 years of age, she was evaluated in view of prolonged fever, cough, and weight loss, going about for almost 1 month. She was extensively evaluated at that time, and her sputum was positive for pulmonary tuberculosis. We unfortunately don't have any documents as such of that, but she received ATT for 6 months. Her repeat sputum done after her treatment was negative, and subsequently, she had good symptom control with weight gain. After 4 years, in 2020, at 10 years of age, again she presented with low grade fever and with some cough going about for 2 weeks. This time there was no history of any weight loss. And at an outside hospital, she was treated as clinically diagnosed pulmonary tuberculosis, where the sputum was negative. This time she received ATT for almost 9 months. From 2020 to 23, from 10 to 13 years of age, she had multiple OPD visits in view of her cough or intermittent dyspnea. So in at 13 years of age, in August 23, she came with intermittent breathlessness since 15 days. She was admitted here at Bharti Hospital with the general pediatrics for observation for 2 days. She had already done an X-ray and CT outside. She was evaluated and she was discharged after observation. Post discharge, she was following up in general pediatrics OPD for almost a year. And in view of these recurrent cough and intermittent dyspnea, she was started on Foracort MDI, 100 2-puff BD in Feb 24. And her symptoms were a little controlled. In September 24, at 14 years of age, this is when she presented to us in pediatric pulmo OPD. Yeah. So as I said, from 2020 to 23, from 10 to 13 years of age, she was having multiple OPD visits where these X-rays were done. I would like Joshi ma'am to comment on these X-rays.
So, good morning, everybody. So, the first radiograph which you have is dated 2021. And as you can see, there are multiple small radio densities scattered over both lung fields. You can also see areas of fibrosis in the upper zone here as well as in the lower zones. The hila appear to be pulled upwards. And other than that, there are some areas where you're seeing relative paucity of lung markings, as this area which I'm showing you here. Her subsequent X-ray done on 5th of July again shows you similar findings. The exposure is a little different. It's a little overexposed as compared to the prior one. You can see the vertebrae and the disc spaces through the heart. But what you're seeing here, and which was a little indistinct here, was this sort of cystic area here with relative paucity of lung markings, which you're seeing better defined on this particular chest radiograph.
Ma'am, your marker is not
The-
seen. Can we show them? The pointer is not seen on
The
this.
rest of the findings are essentially the same. There's not much change between these two radiographs.
Priscilla,
The CP angles, the right CP angle may be
hello,
minimally blunted,
Tanvi.
the left CP
And you
angle
can
is
use the
clear.
marker. What?
And the
Hello.
lung feeds. Sorry?
Hello.
Tanvi, can you use a pointer and show?
That pointer is not seen.
Outside the frame.
Can you see it here now?
No.
No, no. It is outside the film.
Now? Can you see it?
No.
No, no, no.
No.
And now it's moving. Now it's gone into the frame.
I will point.
Is it in?
Yeah.
Yeah, now it's seen. Now
Yeah.
it's seen.
Okay, so can you see this? The white one or the black one? What are you seeing?
The black one.
Black
The
one,
white
black.
one.
The
White one.
white one, no?
You can come to the other X-ray. This X-ray. Second
Okay,
X-ray.
so on this X-ray, the
Yeah.
second one which I showed you, now we are seeing this thin walled cystic lesion far better, probably because it is more penetrated as compared to the other radiograph. And there are multiple small nodular densities which are calcified. Somebody's asked a query on the chat. So yes, these appear to be calcified. And there is mild hyperinflation of the right lung as compared to the left lung. If you see, the volume of the left lung is smaller than that of the right lung. And you're also seeing some amount of tubular opacities here, suspicious tubular opacities in the right lower zone as well. The right CP angle is minimally blunted, the left CP angle is clear. Both lung fields appear slightly hyperinflated. You're seeing about 7 to 8 anterior ends of ribs. So both lung fields are slightly hyperinflated.
So,
I think we have some more radiographs on this.
so this is looking like a thin wall cyst, but the shape of the cyst looks a little odd. Normally, when you see cyst, you want to differentiate it from a cyst, a bulla, or emphysema, or a cavity, right? So this looks like a very odd shaped cyst. So can we comment on the shape of the cyst? Does it lead us anywhere? And we can see, of course, multiple small calcification nodules all over.
So the cyst is a little odd shaped, and you wouldn't expect a cyst in a child. If you were looking at an adult, you would think, is this a large bulla? So, but looking at the rest of the lung findings, probably it is secondary to some amount of lung destruction which has occurred due to the primary disease, which is there, is one possibility. Because of the odd shape, I mean, some amount of fibrosis was there on the right side here. And if you look at the cyst here, the cyst wall and the size of the cyst here on the previous X-ray and compare it with the X-ray done in July 21, this cyst somehow is looking a little more larger and well-defined. So probably it's increasing over a period of time.
Also, the margins of the cyst seem to be calcified, right?
Not really.
Not
It is thin walled and it is a little denser, but I'm not sure if they are calcified. Over here, this inferior margin, there could be some calcification along this inferior margin.
Yeah. And even the medial margin,
Yeah.
like if you continue it up, in
Possible, but
fact.
it could be the other calcifications which are overlying it as well.
Okay.
The
Very
lateral
difficult
margin
to
of the
say
cyst
whether
is
they
not
are in the
well defined,
lungs
right?
or in the cyst wall.
Sorry, I can't hear you.
The lateral margin of the cyst is not well defined, right?
No, the lateral margin is not very well defined. You are seeing something here, but you're not seeing it further.
That is also odd, like
Yeah.
And also, as you said, the vascular markings are reduced, but you can see some tiny stippled calcification even within the cyst.
So possibly that is anterior or posterior to the cyst.
To
yeah,
the
possible.
cyst.
Hence
Okay.
radiograph, it would
Yeah,
be
that's
obvious.
possible.
Ma'am, just from the chat box, is there one more small cyst in the right lower zone above the diaphragm?
Yes.
Could you highlight that
Possibly,
one
yes,
also, please?
Yeah.
possibly.
Yeah.
There is one here as well.
Yes, medially.
And if you look here also, left lower zone, you feel there's a paucity of lung markings.
Yes,
So you need to look at
yes,
it there as well.
So
correct.
probably it's by history it's definitely an ongoing chronic lung disease, and there's destruction of the lung tissue. So maybe there is some pan destruction of the alveolar structure of the lung, and therefore maybe you're getting these chronic cystic lesions. Is that the way we can think as clinicians?
I think so. I mean, it's a chronic disease. It's been there for a number of years. She's had AKT twice. And probably at the end of it, there is some amount of destroyed lung and cicatrization.
And these diffuse calcifications could be something, could it be something like a microlithiasis or something like that? Could that be a thought process? Yeah, otherwise, what could be the TDs for these multiple calcification that we are seeing here?
So one, of course, is tuberculosis, since she's had AKT twice. So tuberculosis itself can calcify. If you have viral infection calcification, that is more diffuse and more uniform and smaller areas of calcification. And they usually don't lead to so much fibrosis and definitely not cyst formation and lung destruction as in this particular case. And alveolar macrolithiasis would be much, much denser and again more diffuse.
Yeah.
Macrolithiasis would look like more like a miliary kind of pattern, right?
Yeah, that,
All over the lung fields.
yeah, that is true. But I was just thinking, what other differentials could
I
I
know,
think of?
very difficult radiologically.
That is the reason I brought out with it could be something like a microlithiasis, and of course, for the sake of discussion, we have two children with microlithiasis, and they also presented like this with cough, breathlessness. And Dr. Sonal, Dr. Hiren, do you any other differentials can you give us here for this? Dr. Hiren?
Theoretically, there are some like fibrotic ILDs. Just that's again just theoretical. I agree that I think this fibrosis and pulling up of the hyla and all these are all signs of this. Possibly in our country it's always TB, but you do get a fibrosing variant of LCH, etc., which may have again dystrophic calcification is very rare in them. So I would still stick to infection only as the possible
Yeah,
etiological
infection looks like
factor.
more
Yeah.
possible thing. Other differences about calcified thing can be some sort of elevated calcium leading to metastatic calcification in the lungs. That is one of the rare possibility.
But
Uh,
again, then it doesn't tie up with the
yeah,
fibrosis
just
and so.
checking, talking as a
Yeah,
differential,
I
like when we see
agree.
calcification,
Yeah, yeah.
what can be else.
What
So
about
calcified mats, that could be another DD on X-ray if we see this kind of multiple calcific deposits.
what about
And then somebody has put a very valid thing, any occupational or environmental lung, any
Exposure,
exposure
yeah.
to, yeah.
what about rheumatological conditions which can cause calcification as well, like a systemic sclerosis, those kind of things?
Ma'am, they
That
again they
lung
cause,
calcification is not that common, ma'am.
yeah, they cause fibrosis and all of that, but lung calcification unlikely.
Do you get calcification in sarcoid? Because sarcoid also causes hypercalcemia. But
Sarcoid,
Yeah,
systemic
yeah.
sclerosis, that
Hypercalcemia can lead to.
yeah,
Yeah, but the sarcoid calcification is more in the nodes, no? That
oh,
eggshell calcification, what we say, it's not in the lung parenchyma.
right.
In this case, there doesn't appear to be any lymphadenopathy either kind of mediastinal difficult to
No
see.
lymphadenopathy. Yes.
Yeah, correct.
Okay, go ahead.
Yeah. So, as I said, she was admitted in 23. So, just before the admission, this was a X-ray which was done outside.
So this radiograph, there's been some motion unsharpness. You can see the diaphragms are quite unclear over here. And other than that, the cyst which we were seeing on the right side is not very well seen over here. Though there is some paucity of lung marking, so possibly it is there. You can see some outline here. And since we know there was a cyst there, we suspect that possibly that cyst is there. Other than that, I'm not seeing much of a difference in the lung findings as compared to the previous two radiographs.
I'll go ahead. So this was the CT which was done outside. Again, because we just have the static images and not the DICOM images.
So these are the lung window images of this child. It's an HRCT. And what you are seeing is there is extensive fibrosis in the apical segment of the left upper lobe. The cyst we were seeing on the radiograph is seen here. It's seen in the posterior segment of the right upper lobe. And it's a pretty large cyst extending downwards. You can see it here.
Yeah.
And there are extensive areas of fibrosis as well, seen in the lungs bilaterally. You can see extensive fibrosis here as well. There are changes of emphysema as well. You can see the epidiameter of the thorax is increased. Other than that, there is a small cyst on the left side as well, what we suspected in this place here. And there is a lot of architectural distortion because of the fibrosis. The calcification is not very apparent on these images, but let's look at the mediastinal window.
Please mute yourself. I can hear some.
This is the next.
This is the next radiograph, and in this what we are seeing is again there are some fibrosis there in the right, middle, and lower lobes. These are the coronal formatted images which are showing you the large cyst which we saw on the radiograph. It's more in the posterior segment of the right upper lobe. You can see the extensive fibrosis and the hyla being pulled up over here. And all in all, the changes are, whatever the findings are very similar to what we saw on both the radiograph, on all three radiographs. We have mediastinal windows. There are more lung window images, and they're showing you similar findings. A lot of fibrosis and the same cyst here, more fibrosis here, the cyst on the left side, and these probably are the areas of nodular calcification which we were seeing on the chest radiograph, but we'll see them again on the mediastinal window. But you can see that the lungs are hyperinflated. There is an increase in the epidiameter, so some amount of emphysematous changes have also happened.
We don't have mediastinal windows.
One question: at that time of CT was done, what were the
So we
symptoms that
don't
was
have
present?
mediastinal windows at that time. We only have this particular set of images.
So in 2023, when she was around 13 years, she came with the CT and X-ray with the pediatric OPD, and I think she was admitted under pediatric unit. So we were not involved that time.
No, but at the symptoms, what were the symptoms like?
So
Same symptoms: cough and recurrent cough and some
Breathlessness
exertional
ongoing.
But no fever, no sign.
No
No
fever.
fevers.
So can we just, by looking at these CT images, it looks like some ongoing chronic lung disease, which
Yeah.
is fibrosing, and the cyst formation could be probably secondary to destruction of the lung parenchyma. And you will not call it a solitary lung cyst, isolated. These are multiple cysts actually. You have more than one, and they're thin wall cysts. There are no cavitation, no emphysematous bullae, nothing, right? And with some calcification.
And just to add few more findings that cysts are asymmetrical. They are in different distribution. They are not looking like what we see in diffuse interstitial lung disease kind of pattern or
Right.
cystic lung disease that is diffusely spread. That is not kind of story. So it looks like more of a acquired destruction rather than what we see in LAM or other interstitial lung disease. Even the fibrosis is there, but fibrosis also is very asymmetrical, not following the symmetricity. So that also indicates that more of a acquired insult. rather than underlying interstitial disease or underlying cystic disease. That is my take on this, I think.
Yes, sir.
Go ahead.
Should I? Yeah.
PFT was done anytime.
Yes, sir. I'll come to that, sir. So in a
So,
summary,
if I sorry, I can just add one thing. The margins of the cysts are very irregular. So, and they have those fibrotic lines around them. So that again, suggests a lot of cicatrization, which has caused the cyst formation. And the walls are not imperceptible. The walls are very perceptible.
That's
So
right.
again,
That's right. You can see the calcifications also along the wall.
walls,
Along the
yeah.
wall, you can see calcification.
Okay, that's all.
And at this point of time, I think with the history of 2 times being treated for tuberculosis, it seems like a destruction of the lung following TB is as the most probable diagnosis at this point of time, because there is no other systemic symptoms as well.
yes, ma'am.
Right.
And also the way that cysts are so randomly distributed, it doesn't fit into any other condition.
Yes, ma'am. Uh, So, yes, summary wise, she's a 15-year-old girl with recurrent dry cough and exertional dyspnea, with previously treated as TB with multiple cystic lung lesions. And clinico-radiological, as we already discussed, it most likely looks like a post-TB sequelae with probable asthma. Just to rule out other causes of cystic lung disease, even though it does not fit in because we don't have other symptoms, but HP, hyper IgE, and LCH were in our mind. So, just seeing post TB sequelae, the points in favor were that she had a history of tuberculosis in childhood, she had dyspnea on exertion, and she was underweight. The points against are that it can't be explained only by post TB sequelae because she has a recurrent dry cough which is responding to bronchodilators. So, there is a add-on thing which is going on. And as we discussed, the radiological findings, there's a lot of fibrosis, calcified nodules, and cysts. And usually in post TB sequelae, we might also be able to see thick walled cavities, bronchiectasis, and pleural thickening. HP again doesn't likely fit in, but just points in favor were that she had a dry cough ongoing for long and dyspnea on exertion. But she didn't have any fever or known exposure, no occupational exposure. And the classic radiological findings of HP, like GGOs, air trapping, mosaic attenuation, were not there. There were no, some lung cysts were there. Usually in HP, there are centrilobular nodules and few lung cysts, and they are present within the areas of the GGO. There is fibrosis in fibrotic HP, and usually a upper and middle lobe predominance of these cysts. Hyper IG, the points in favor that she had these recurrent respiratory complaints ongoing and she's underweight, but she didn't have any recurrent skin abscesses, no recurrent pneumonias, or any multifocal infections. And usually in hyper IG, the lung cysts usually represent the pneumatoceles, which are secondary to staphylococcal infections. LCH, again, because of the chronic respiratory symptoms going on for so long, but no fever, no other systemic manifestations, no hepatosplenomegaly, no skin manifestations, no lymphadenopathy, no bony involvement. And in LCH, as we were discussing, it's usually a symmetrical micronodular infiltration. It can present with cavities, symmetrical upper lobe and middle lobe cysts, also in the costophrenic angle, and they're variable in size, irregular shape, and they're thin walled. So just to give the classic pictures of LCH, on the left hand side is LCH, and the right hand side is like hypersensitive pneumonitis, showing a lot of fibrosis, GGOs, and mosaic attenuation. So we went ahead and did certain investigations.
So now this is when she presented to us, right, Tanvi?
Yeah.
Yeah.
Yeah. Just one second. Yeah. So on CBC, her HB was 11.1, count of 6,200, and a platelet of 2.2 lakhs, neutrophils of 85%, and a lymphocyte of 11% with 2% eosinophils. We went ahead and did a full PFT, a Spiro showing a mixed pattern with a good bronchodilator response of 15%. DLCO was normal. Body plethysmography, the TLC was normal, and the RV TLC was high, suggestive of air trapping. We did a 6-minute walk test, which was 49% predicted. Induced sputum was done to rule out tuberculosis, any active tuberculosis, which was negative. In view of these chronic respiratory symptoms, we did a 2D echo, which was normal. There was no evidence of pulmonary arterial hypertension. As we discussed, there were a lot of calcified nodules seen. We just wanted to evaluate and rule out sarcoid. We did a ophthal, which was normal, and calcium creat ratios were also normal. IgE was more than 1,000, and a stool routine was done, which was normal. Then this is when she presented to us. We had repeated an X-ray. So this is an X-ray of September 2024. Ma'am.
So on this radiograph, what you're seeing is this thin wall cyst which we were seeing earlier. It's almost unchanged. Multiple tiny densities are seen along the margins of this cyst. Other than that, we are seeing the fibrosis which we saw earlier. We are seeing multiple calcified densities scattered over both lungs. So all in all, there doesn't appear to be, and the suspicious cyst in the left lung as well. Maybe on the right side also, that cyst which we saw somewhere in this area is also there because of this increased lucency here. So all in all, it's looking almost the same. Maybe the left lung, which was looking a little smaller earlier, is looking a little better here. But again, it's subjective. And I don't think there is any real significant change between the radiographs. Here, you're seeing the left upper lobe fibrosis as well with the pulling up of the hilar. So whatever it is, looks more like a post-infective sequelae is what we reported it as.
Is there any leak around the
calcifications better, difficult to say. We really need to compare radiograph with radiograph and look at the exposure of the radiographs.
Is there a slight air leak on the left side?
So
Sorry?
is this pneumomediastinum kind of thing? That's what I think somebody wants to.
Along the left
Yeah.
margin, maybe it's a summation shadow of the air in front or behind. Let's have a look. We have a CT after this as well.
So we've done an X-ray skull to rule out LCH. And CT, ma'am, we can share the images.
So I'll just share the DICOM images of the CT.
I'm going to stop sharing.
That was her scanogram. And again, there's not much of a difference as compared to the chest radiograph.
We can't see.
And we can't see the images.
Like that is seen. Yeah. Is it seen now?
No. Yeah.
Yes, ma'am.
Yeah?
Yes, ma'am. No.
Okay, so that is the scanogram. This is the HRCT. We are starting from below upwards. We normally scan below upwards because the movement is maximum at the level of the diaphragms. And if a child or an adult cannot hold their breath, the motion would always be at the end. So we always scan from below upwards to make sure the motion is less at the level of the diaphragm. And you can see both lungs, the hyperinflation we saw earlier, multiple thin-walled cysts, some of them showing calcification at the margins, extensive fibrosis here, calcified lesions as well. The fissures also appearing thickened. This is the large cyst we saw earlier. And rightly said by somebody, there are multiple tiny calcifications seen at the periphery of the cyst. A lot of fibrosis. Again, cysts in the left apex. So I'll show you the contrast thin images. And now we are coming from above downwards. So you're seeing a few mediastinal nodes there, which are pre and paratracheal. That's the left main pulmonary artery, which is being pulled up. That's the right main pulmonary artery. There's one node here at the right hilum, which is hypodense and poorly enhancing. There's calcification there as well. Here as well, you're seeing a small, at the left hilum also there's a node with calcification. There's calcification of subcarinal nodes, extensive calcification there. And there's a large calcified lesion in the right lower lobe. Multiple calcified densities are seen scattered over both lungs. The liver and the spleen were essentially unremarkable, and the kidneys were also okay. Suprarenals were fine. There are some calcified lymph nodes, multiple calcified lymph nodes in the abdomen as well. So all these are pointing towards a possible old infection, a granulomatous infection like tuberculosis and sequelae. These are the coronal reef formatted images. So that's the right upper lobe bronchus you're seeing there, and that's the posterior lobe bronchus and the cyst there, and that's the anterior lobe bronchus, anterior and apical, and that's the bronchus intermedius, and you can see the extensive fibrosis there surrounding it. And the multiple other cysts, they are better seen, better delineated on the coronal images. Should I go ahead?
Should I go ahead?
Yeah, Tanvi, please.
Dr. Panwala wants
So
to add.
just some static images which we just saw.
Just one second. Dr. Hiren sir, Dr. Sonal ma'am, would you like to also comment on the CT films we just saw?
Yeah, what Dr. Prishan described, that is a finding. We are not seeing any signs of active infection within the lung, and the cavity region was, I think, reducing in size as compared to the previous scan, especially in right upper lobe. That was the visual appearance.
Yeah, I think I'm.
Thank you, Tanvi. You
I
can.
think the whole point we wanted, I think, from the radiologist was whether some active process is going on or it is a static thing, because the 2021 also the X-rays were similar. 2024 more or less no change. So I think that was always on the back of the mind, whether there is active maybe tuberculosis or any other process going on, or it is just the sequelae. That was the most important question.
Did you all do a bronchoscopy to look for any the AFP smear?
No, we did not do actually.
That will only tell us whether it's active or not, right?
Sputum was done twice, I think, GL and induced sputum, which was negative.
Maybe we could do a bronchoscopy and look
Yeah,
at.
we contemplated at some point, but I think future courts will tell you that she responded, so we'll go that. But we had counseled them; they were not very willing. And after consultation with radiologist, I think they said that this is looking more of a sequelae rather than a progressive disease. So I think
So
we stopped.
what I find so strange is that there are some children, and see the way she has received anti-tubercle therapy twice, right? One at the age of 6 years and one at the age of 10 years.
Yeah, that 6 year was proven to be. 10 year was a clinically diagnosed.
And in between the 6 and 10, she still had symptoms, or
She was like actually better, ma'am. I mean, she was not complained that cough and intermittent breathlessness was very minimal. As such, she was not, going multiple OPD visits were not there.
Yeah.
From
So
10
basically,
years
the presentation
onwards,
was from 10 years onwards. 6
yeah.
to 10, though we don't have any, unfortunately, we don't have any X-rays also of that 6 years and 10 years. So all
But
this
so
happened.
many children are treated for TB, and she looks like she was properly treated and fully treated, and still she landed up with so much of a chronic lung disease.
Yes.
That is so strange. Is it something genetic? Is there something predisposing?
Yeah.
I had one child like this a while back, and this was during COVID. Her father had TB, and she probably contracted it, and she had a slow smoldering TB, and she was not treated. Okay, and this child presented to us with recurrent pneumothorax, and we finally diagnosed TB on doing a lung biopsy, and we got gene expert positive on that, and she was a drug sensitive TB, and she had 7 pneumothoraxes, and her lung was completely destroyed because of that smoldering TB. This kid was treated, and still the lung has gone this way. I really don't
Yeah,
know.
but this child actually, speaking apart from chronic cough and OPD visits, she was otherwise well preserved for some weight loss. There was no fever at any point of time, absolutely no fever. So that was also there. So the question was whether it is something active or this is just a sequelae. And since we had those old X-rays, we digged into those X-rays and then found out that there were cysts, and they were unchanged. I think even 2021 to 2024, the cyst remained same. So that was the pointer that probably we were dealing with something which was an old damage and the static disease. I
Cyst
think.
apart, the lung is completely destroyed.
Yeah,
That is
yeah.
also an issue. But like you wonder when the child is fully treated, even it doesn't look like an MSMD, which can have recurrent infections. It doesn't fit into an MSMD. Also, looking at her age and
Yeah.
you all don't have a microbiological diagnosis on her, right?
No.
6 years she had that TB positive. 10 years it was clinically proven.
Mycobacterium bovis.
And 2023 also she was investigated for tuberculosis when she was admitted with pediatric unit. And again when she came to us, again we investigated for tuberculosis sputum and gene expert which was negative. And active infection signs were absent. So I think the progress and the further course probably will
The,
answer some of the
the
questions.
only positive finding she had suggestive of activity were the lymph nodes in the hila. They are hypodense and poorly enhancing nodes at both hila. So I don't know whether they would suggest some amount of nascent activity or something like that.
Ma'am, is there more fibrosis in these scans also compared with there is progressive destruction in the sense as compared to the old CT? The fibrosis calcifications are more than what we saw in the previous one.
No, they almost the same. You compare the previous one or this one.
Thank you.
Go ahead.
Tanvi, you can proceed.
Yeah. So our working diagnosis was a post-TB sequelae with asthma. And the further course, so she was on Foracort 200, which is total of 800 mcg per day. And in view of, as the symptoms were still, the cough was still there, dry, we escalated it to 1200 mcg per day. And later we even had to add tiotropium MDI 9 mcg, which was added. But on follow-up now, since last, like from 1 year, September 24 to now, her symptoms are improved. She's clinically better and she's doing well. So we are even tapering the Foracort now on OPD basis. And she's good. Currently, she does not have any dry cough or breathlessness. She's going to school and she's doing well. So just wanted to discuss few things which we've already discussed with the radiologist, but just to go over it. So a cyst is basically a thin wall. It is less than 2 mm. The contents are mostly air, sometimes fluid or solid. And the associated features are that they are round, circumscribed, surrounded by an epithelial or fibrous wall of various thickness with normal surrounding lung. A cavity is thick walled, which is more than 4 mm, and it can content can be air, fluid, or debris, and it is often within a consolidation mass or a nodule. A bulla again a very thin wall, less than 1 mm, but they are large. They are almost more than zero point 0.5 centimeter in diameter, and they are bordered by remnants of alveolar septae or pleura. A pneumatocele is thin valve and usually occurs post-infectious or traumatic, and it's like a parenchymal cyst, but within it arises from the over distension of the lung and often resolves spontaneously, and it is usually followed by a known insult, post-infectious or traumatic. And emphysema, there's no visible wall, and there's a central dot sign where we can see the pulmonary artery, and there are irregular lucencies. And the other terminology is cystic bronchiectasis, which looks way different from lung cyst, and they're thick-walled, non-tapering bronchi producing tram track ring opacities and tubular structures representing the filled airways. So just to we've seen, so what we had was a cyst. This is a cavity which is thick walled, more than 4 mm. This is a cyst, and these are bulla. The bulla locations are usually subpleural, and they're large in diameter, almost more than 0.5 centimeter. So, when we talk of these diffuse cystic lung disease, we've already discussed, but just some differentials which we can think of. Usually in our country, the first would be infection associated. It can be bacterial, staphylococcal pneumonia or tuberculosis, parasitic infections, fungal diseases, or PCP pneumonia, respiratory papillomatosis. Associated with ILD and occupational is hypersensitivity pneumonitis. Neoplastic can be pulmonary LCH. Immunodeficiency, we have hyper IgE syndrome. Associated with lymphoproliferative disorders, we have LIP, which is lymphoid interstitial pneumonia, follicular bronchiolitis, and IgG4 related disease. Some rare causes which are associated with genetic mutations can be LAM, lymphangiomyomatosis, Bird-Hog-Dube syndrome, Proteus syndrome, Ehlers-Danlos, and Marfan's. So I just wanted to discuss some of the DDs. The LCH, hypersensitivity pneumonitis, infections we've already gone through. Lymphangiomyomatosis, it occurs sporadically or in association with tuberous sclerosis. It's usually in women of reproductive age. They present with progressive dyspnea, recurrent pneumothorax, chylus collections, occasional hemoptysis, thoracic and abdominal lymphadenopathy, and thoracic duct enlargement. Extrapulmonary manifestations include hepatic and renal angiomyolipomas or meningiomas. And the radiological features are that there are diffuse thin walled cysts, 2 to 5 mm, no lobar predominance, and the intervening lung parenchyma is absolutely normal. There can be chylous infusions or can present with spontaneous pneumothorax. So, just a radiographic image. So, this is a 30-year-old female. We can see multiple thin wall cysts, and they are distributed quite symmetrically, and the intervening parenchyma looks normal. Then the second is Bird-Hog-Dube syndrome. It is autosomal dominant. They present in adolescent, and they can manifest symptoms by the fourth to fifth decade of life. And they're characterized by formation of hair follicle tumors, so skin involvement, kidney tumors, pulmonary cyst, and can present with a recurrent spontaneous pneumothorax. Many a times there's a family history of spontaneous pneumothorax or kidney tumors. Radiological wise, they also have thin wall cysts, and the predominance is usually lower lobe. The cysts are quite elongated and lentiform in shape. They usually are located in subpleural and paramediastinal, and again the lung parenchyma is quite normal. So just to give an example, we can see the small cysts which is present in the subpleural region, and the parenchyma looks normal. Then we have lymphocytic interstitial pneumonia, which presents in the middle-aged woman. It's associated with various disorders, including HIV, connective tissue disorders like Sjogren's, Hashimoto thyroiditis, and SLE. They present with dyspnea, cough, fever, weight loss, recurrent pneumothorax, and systemic features associated with the underlying disorders. The radiological picture is diffuse, cyst, subpleural, and perivascular in location. And there are diffuse or multifocal GGOs seen. There are poorly defined centrinodule nodules which can be seen, and there's interlobular septal thickening. So this is an example where we can see GGOs, we can see cysts, a lot of centrilobular nodules, and interlobular septal thickening. So if just the algorithm which we can use, if we have cystic air spaces, the first step would be to see, are they true cysts? You have to exclude any cavitatory disease, any centrilobular emphysema or cystic bronchiectasis. Once you've identified that these are true cysts, we have to see if their location is what. If the location is intraparenchymal, we'll go further. If they are subpleural location, we need to see if they are bullae, are they paraseptal emphysema, or is there any honeycombing present. Once we know they are intraparenchymal, we will look at the entire CT scan. If they're associated with GGOs on the scan, then the likely differential can be pneumocystis jirovecii pneumonia or desquamative interstitial pneumonia. If they're associated with nodules, then we can have lymphoid interstitial pneumonia, we can have light chain disease, amyloidosis, and pulmonary LCH. If they are without any CT findings, are they only solitary or incidental cysts? Differentials would be incidental cyst, pneumatoceles, or bronchogenic cyst. And like if they are multifocal or diffuse, as we discussed above, it can be Birth-Hog-Dube syndrome, tracheobronchial papillomatosis, lymphoid interstitial pneumonia, any malignancy, metastasis, infections, LAM, and LCH. So just going through some literature which I found in post-TB sequelae in children and adolescents. So the key clinical and radiological findings that pulmonary sequelae is present in 1 to 49% of children post-tuberculosis, and common findings are fibrosis, calcifications, atelectasis, emphysema, and bronchiectasis. And they present with persistent symptoms of wheeze, cough, dyspnea from months to years after treatment. Cystic changes are rare but may result from broncholar obstruction and necrosis, and the lung function will usually be mixed obstructive and restrictive pattern. And for the respiratory morbidity, there was a study done in Nordic Baltic cohort which showed that TB is associated with almost 2 times higher asthma risk, and they present with increased wheezing, breathlessness, and a sleep disturbing cough. That's all. Thank you.
Thank you so much. That was a nicely discussed case of all cystic lesions in the lung. You mentioned asthma in these children. Is it actually asthma, or is it more like an obstruction because of a destruction, and which manifests like asthma? Because I think it definitely has to be restrictive with obstructive component, and in the true sense may not be a definition of asthma, according to me, is what I can understand.
So, ma'am, it showed both. It can be like a post-TB sequelae showing some bronchial obstruction. That's why presenting with these wheezing episodes. But there are also known to have like tuberculosis. They can have a risk of asthma later on with having asthma qualifiers like nocturnal symptoms and trigger-induced symptoms and stuff like that. So yes, ma'am. So I read literature which showed both, that it can just be because of the post-TB sequelae, but it can also that they can present with asthma in a later life.
TB is known to cause hyperactivity, madam. A child without pulmonary tuberculosis, he is known to develop airway hyperactivity and asthma. So it is possible post TB.
Yes. So in this particular case, the reason I
Just
thought,
to add, Indu, like
yeah,
post TB, if we are talking of airway involvement, it could be something like a bronchiolitis obliterans, where you will not get a responsive, reactive. It will be present with asthma, but bronchodilator response would not that much. It will be more of a restriction. Whereas in this child, there was a 15% bronchodilator response, good response to ICS LABA combination in due course of time. And so I think there was a reactive component, but as you said, definitely some restrictions or a lot of restrictions was expected because of fibrosis and cyst. Fortunately, or whatever, the body plethysmography was normal. So restrictive component as such, interstitial lung disease was not that much. It was more of a probably air trapping, which was giving that
Mixed
picture.
pattern.
Yeah.
you mentioned about Marfan's as one of the differentials, right? But they present with, I think, more spontaneous pneumothorax.
Spontaneous pneumothorax. Yes, ma'am.
Generally not come with lung.
Yeah. So if they might have last cysts, which probably become pneumatoceles and then present as spontaneous pneumothorax. Yeah.
More recurrent spontaneous pneumothorax.
Yes.
Any other questions? Any other? Tanvi, will you take anything?
ma'am.
In the chat box?
Are there any more questions? As we've answered everything in the chat box so far. Are there any more comments, any more questions from anyone in the audience?
Dr. Savar Agarwal, do you have anything to say?
Not really. Thank you so much.
I see also Dr. Rashmi Kapoor here. Any comments, Rashmi? Do you see so much TB in your part of?
Yeah, my only this thing is that after a complete course of ATT, one could do BAL to see whether there's any remnant active TB or not. And that is generally recommended also, that you have to see that the lungs are clear of any tubercle bacilli after the end of the treatment. That's all. Yeah, very well presented case. Very well.
Thank you, ma'am.
Rashmi, you see so much TB. Do you see so much sequelae with calcium?
We see a lot of TB and a lot of various presentation we see a lot of stenotic segments of tracheobronchial tree, a lot of it. And in many, we've done some balloon dilatation also. But, the parents are not agreeable to get anything else done because the child is okay. At that time, child is okay. Even if right upper lobe, say, is stenosed. He right now is not having problems. So we explain, but they do not listen. So I have a lot of, but yes, I have not seen this kind of a presentation in tuberculosis.
That's why I was wondering whether we should look at doing certain genetic tests for this child. I don't know if we will get any.
We had thought that we'll plan it, but now as she's doing well on treatment, we thought we can wait and we can plan it. Yes, ma'am.
Because that's a little unusual manifestation, and especially after being treated. The patient that we had who did so badly was not treated. So there we thought it was and it was during COVID. She was inside the house, her nutrition was compromised, and her lungs gradually kept on getting destroyed. And that we thought was the reason for her recurrent pneumothorax, because she developed all Pulmo all over them. But this child was treated. So that's why I was just wondering if there is something underlying, because this is not a usual presentation, is my thought process.
So, so many times it happens that the patients are not treated properly. So this kid must have been treated elsewhere. We don't know what kind of whether she took the complete course or not, whether she really took the intensive and the continuation phase properly in proper doses or not. Because this has been our experience that children come after taking ATT, but that is absolutely half the dose of what is recommended.
I agree with
Absolutely. I think that was the problem. This child actually came from periphery, I think Shahapur or somewhere. And we don't know. We don't actually have no papers actually whether she was.
Yeah. It must have been absolutely a low dose and not a complete dose, I can assure you, because I've seen it n number of times.
Absolutely.
See all the time. That is true. Because you mentioned she was fully treated. That is the reason I brought out this.
6 years she was treated, and then 10 years
And
empirically.
twice, not once, twice.
Yeah. Once empirically, but yes.
All right. Thank you so much, everyone, for joining.
Thank you all.
Thank you.
Thank you, ma'am.
Bye-bye.
Bye all.
Thank you everyone for an excellent presentation.
Yes,
Our
the
sir,
slides
our
are very
beloved
good.
mentors. I think we've gone
Yeah,
back to sir
and
after yet another session, and with the approach to cystic lung diseases. Thanks to everyone today, and looking forward to the next session. Have a nice day.
if possible, Dr. Tanvi, those your cystic lesion summary was really amazing.
Yes, ma'am.
So if possible, could you put up the slides for everyone's benefit
Sure,
right now?
Definitely.
Because they're summarized really well.
Okay, ma'am.
There is a very brilliant article in Chest, which I think she has taken it. That's those big images from there. That article is a must read. I will share that article also.
Yeah. Sure.
Okay.
Okay. Bye-bye all.
Thank you.
Thank you, Sanjay sir. Thank you, Priscilla ma'am. Thank you, Tanvi. Thank you, everyone.
Thank you
Have
so
a
much.
nice day.
Thanks.